Hello and welcome back to another ACLS exam prep video. This is Nurse Eunice with Florida Training Academy, and today's video will be discussing ACLS drugs or ACLS medications, and we will begin in about 10 seconds. If this is your first time tuning into our channel, please grab pen and paper. You're welcome to put your answers in the comment area, and don't forget to download our free ACLS study materials, which will be found at fltraining.com. It has study materials, algorithms, and pretty much everything you need except for your current ACLS manual, which you'll need to take into the testing location whenever you take your ACLS exam. So ACLS stands for Advanced Cardiovascular Life Support. This is the care that is provided beyond BLS. So in your BLS videos, when they're calling for the rapid response team and the nurse who comes and starts the IV, well, she needs to know what medication to push in the IV, as would the doctors. So advanced cardiovascular life support is usually a course for nurses, doctors, respiratory therapists, and pharmacists. It's also a course for nursing students. Do understand that medications and dosages may change based on research. So when in doubt, follow your organization's protocol, and we're going to begin right now. So number one, which drug is the first line treatment for ventricular fibrillation in ACLS? Is it amiodarone, lidocaine, epinephrine, or atropine? And hello, Anne-Marie. The correct response is C, epinephrine. Epinephrine is the first-line drug used in the treatment of ventricular fibrillation and pulseless ventricular tachycardia. It is administered to increase coronary and cerebral perfusion during CPR. Question 2. Which medication is commonly used for the management of symptomatic bradycardia? So symptomatic, that means that they are dizzy, they're short of breath. Bradycardia, the heart rate is less than 50. So for advanced cardiovascular life support purposes, bradycardia is not when the heart rate is less than 60, it's less than 50. So would you give dopamine, atropine, adenosine, or amiodarone for symptomatic bradycardia? If you chose B, atropine, you're absolutely correct. Atropine is the first line treatment for symptomatic bradycardia. It works by inhibiting the vagus nerve, thus increasing the heart rate. Question number 3. What is the primary mechanism of action of adenosine in the treatment of supraventricular tachycardia? So this would be a narrow complex tachycardia with rates above 150. So would it be A, beta blockade, B, calcium channel blockade, C, potassium channel blockade, or D, AV nodal blockade? And I'll give you a few moments to review that before I show you the correct answer. Revealing the answer in 3, 2, and 1. The correct response is D. So adenosine acts by transiently blocking the AV node, which interrupts reentrant pathways and can terminate SVT. And so there's an arrow there pointing to the node. It says the AV node. And this is why if a person has severe SVT or reoccurring SVT, they can go to the EP lab where they can actually have an AV node ablation, and that's going to help control their heart rate long term. Number 4, which of the following drugs is recommended for stable narrow complex tachycardia that does not respond to vagal maneuvers? So you've asked the patient to bear down, but their heart rate is still above 150 or still above 100. This one's narrow complex tachycardia. All right, so would you give amiodarone, lidocaine, adenosine, or epinephrine? Narrow complex tachycardia that does not respond to vagal maneuvers, and this should be an easy one. If you chose C, adenosine, you are correct. Adenosine is the correct drug for stable, narrow complex tachycardia if vagal maneuvers are ineffective. Question number 5. What is the initial dose of amiodarone in the treatment of pulseless ventricular tachycardia or ventricular fibrillation. The initial dose of amiodarone, is it 150 milligrams, 300 milligrams, 1 milligram, or 0.5 milligram? And so the first dose of amiodarone is the big dose. Remember, this is a cardiovascular emergency. This person is deceased. They're in cardiac arrest. So the first dose of amiodarone is going to be the higher dose. It's going to be 300 milligrams. Your second dose would be 150 milligrams. Number 6, which of the following is the correct dose of epinephrine during a cardiac arrest? A, is it 0.1 milligram IV every 5 minutes? B, is it 1 milligram IV every 3 to 5 minutes? Is it C, 0.01 milligram IV every 3 to 5 minutes? Or is it D, 10 milligrams IV every 10 minutes? So this dosage doesn't change, it's pretty consistent. And if you chose B, 1 milligram IV every 3 to 5 minutes, you are correct. So a good rule of thumb is to administer epinephrine every other cycle. So about every 4 minutes, we would give epinephrine. And you start with your first cycle. So first cycle would be epi, 1 milligram. Second cycle would be amiodarone, 300 milligrams. Number 7, what is the first line drug for treating torsades de pointes? Is it A, magnesium sulfate, B, amiodarone, C, lidocaine, D, atropine? The correct response is A, magnesium sulfate, and a rationale. Intravenous magnesium is the first-line pharmacologic therapy in torsades de pointes. Magnesium has been shown to stabilize the cardiac membrane in torsades de pointes, a specific form of polymorphic ventricular tachycardia. So when you're doing your pre-course assessments, which are required for your advanced cardiovascular life support, you're going to have to review strips. And so if in the strip, it is not, if it's looking like this, where it's twisting of the points, that's what torsades de pointes means. You're also going to have to consider giving the patient magnesium sulfate so that we can control their irregular heart rhythm. Number 8, in ACLS, what is the recommended dose of atropine for asystole or pulseless electrical arrhythmia, PEA? Is it 1 milligram, 0.5 milligram? C, atropine is not recommended for asystole or PEA, or D, 2 milligrams? So think about your cardiac arrest medications. What medications are given for your non-shockable rhythms such as asystole and PEA? And if you chose C, you are absolutely correct. Atropine is not used for asystole or PEA. Atropine is used for bradycardia. And so always refer to your advanced cardiovascular life support guidelines, refer to your book. But for asystole or PEA, it's pretty much CPR and epinephrine. And of course, get into those reversible causes as soon as possible. Number 9, which medication is used to manage ventricular arrhythmias when amiodarone is not available? Is it adenosine, lidocaine, atropine, or dopamine? So which of these would be an antiarrhythmic? For this one, it's not adenosine. It would be B, lidocaine. We in the US, we usually always have our amiodarone, so we don't have to usually use lidocaine, but lidocaine is an alternative to amiodarone for the management of ventricular arrhythmias if amiodarone is not available. So remember, the information that we're providing is not just for United States, it's globally because the research is based off of international research. But we have to be mindful that not all drugs are available in all regions of the world. Number 10, what is the recommended infusion rate for dopamine when used for post-cardiac arrest care? Is it 2 to 10 micrograms per kilogram, zero point 0.5 to 2 micrograms per kilogram, 5 to 20 micrograms per kilogram, or 20 to 30 micrograms per kilogram? So the person, they have a pulse. If they're not breathing, we're going to intubate them, connect them to the vent, but we have to get those blood pressures up. You're starting a dopamine infusion. What is the dosage? Great job. If you chose C, 5 to 20 micrograms per kilogram, you are correct. That is the recommended infusion rate. Remember, you want to titrate to the patient response. So you just don't want to start off at 20 micrograms because that may be too much for that patient. So you want to start it off at 5 and then work your way up. And once you have the pressure stabilized, you can hold it. Once the patient improves more, you can start slowly tapering the dopamine so that we can eventually take it off and discontinue it. Number 11, which drug is indicated for severe hypotension when fluid administration is not effective? Is it adenosine, amiodarone, dopamine, or lidocaine? And I think I gave you that answer. So you should get this one right. Yes, you're absolutely correct. It is C. It is dopamine. So dopamine is used for severe hypotension, especially when fluid administration does not effectively increase blood pressures. Question number 12. What is the mechanism of action of magnesium sulfate in the treatment of torsades de pointes? Is it A, beta blockade, B, sodium channel blockade, C, calcium channel blockade, or D, stabilization of cardiac cell membranes? Revealing the answer in 3, 2, and it is D, stabilization of the cardiac cell membranes. So magnesium sulfate works by stabilizing the cardiac cell membranes and is effective in the treatment of torsades de pointes. Number 13, which drug is the first choice for the management of stable monomorphic? So it's all originating from the same source, so they all look similar versus torsades de pointes where it's all twisting. So for this one, it wouldn't be magnesium. What is the first drug of choice for the management of stable monomorphic ventricular tachycardia? Is it atropine, amiodarone, lidocaine, or epinephrine? Which of those medications are an antiarrhythmic? Yes, that's absolutely correct. Great job. It is B, amiodarone. So in stable patients with monomorphic ventricular tachycardia and normal left ventricular function, restoration of sinus rhythm is typically achieved with intravenous amiodarone. Due to its antiarrhythmic properties, IV procainamide or sotalol may also be used. Number 14, in ACLS, what is the maximum cumulative dose of lidocaine for ventricular arrhythmias? Is it 2 milligrams per kilogram, 3, 4, or 5 milligrams per kilogram? And since we rarely give lidocaine in the facilities I've worked in, I know this one may be a little bit tricky for you, so I'm going to reveal the answer. If you chose B, 3 milligrams per kilogram, you're absolutely correct. So your doses span between 0.5 to 0.75 milligrams per kilogram up to 1.5 milligrams per kilogram. But regardless of the range or the dose that you choose, at no point can you give more than 3 milligrams per kilogram. 15. What type of fluid is most appropriate for the initial resuscitation of a patient experiencing cardiac arrest due to hypovolemia? Remember those H's and those T's. So if your patient is hypovolemic, do you want to give 5% dextrose in water? Do you want to give normal saline? Do you want to give half normal saline? Or do you want to give lactated ringers? All right, revealing the answer in 3, 2, 1, and I do see the correct response. If you chose B, normal saline, you are correct. So sodium chloride is an isotonic crystalloid solution that expands in the intravascular volume, making it suitable for initial resuscitation in hypovolemic cardiac arrest. Lactated ringers is also appropriate, but remember we talked about pushing those ACLS drugs. We can't mix the ACLS drugs with lactated ringers because it has electrolytes and it can actually cause complications. It may not be compatible with a lot of the ACLS drugs. So usually during the code, we hang normal saline and we can push our medications in with the normal saline. If you want to hang lactated ringers, you'd have to have a separate IV line. Number 16, which medication is used for the treatment of beta blocker overdose in ACLS? So your patient had too many of the LOLs. They took too much of their metoprolol. So is it going to be calcium chloride, atropine, glucagon, or epinephrine? Miss Dixie was confused. She took too much of her blood pressure medications, and now she's suffering from a beta blocker overdose. How do you treat it? Barad, you're rocking it. Yes, it is glucagon. So glucagon is used for the treatment of beta blocker overdose because it increases the heart rate and contractility through a mechanism independent of beta adrenergic receptors. Number 17, what is the appropriate dose of epinephrine for moderate anaphylaxis? So this is not someone who's in cardiac arrest. This is someone who is having an allergic reaction. It said moderate. So this is what I want you to think of. What is the dose of medication in an EpiPen? Is it 0.1 milligram IM, 0.3 milligrams IM, 1 milligram IV, or 0.5 milligrams IV? I helped you out. It wouldn't be IV if it's just moderate anaphylaxis. Yes, you are correct. It is B. It is 0.3. So for anaphylaxis, the appropriate dose of epinephrine is 0.3 milligrams IM. And usually the EpiPens come in only 2 dosages. It's going to be 0.15 or it's going to be 0.3. So IV administration of epinephrine, as far as anaphylaxis is concerned, is reserved for severe cases. Question number 18. Let's look at this rhythm. Which ACLS drug is contraindicated in patients with Wolff-Parkinson-White or WPW syndrome who are also presenting with atrial fibrillation? So we have our wide and bizarre complexes. That would be the ventricular tachycardia. And then we have the smaller irregular complexes. You really can't, see a P wave, but that would be like or you can't designate or just pick out one solo P waves. It's just really wavy. That would be atrial fibrillation. So this patient, their heart is irritated. What drug do you not want to give? Do you want to give amiodarone? Which drug is contraindicated? Let me rephrase that. Is amiodarone contraindicated? Is adenosine contraindicated? Is procainamide contraindicated? Or is lidocaine contraindicated? Which drug would you not give to someone who has WPW with atrial fibrillation? And I am so proud of you. If you chose B, adenosine, you are correct. So all of the other drugs we can give with WPW. We can give amiodarone. We can give procainamide. We can give lidocaine. What we cannot give is adenosine. So the AV node blocker should be avoided in atrial fibrillation with atrial flutter and WPW syndrome patients. In particular, avoid adenosine, diltiazem, verapamil, and other calcium channel blockers and beta blockers because they can enhance conduction through the accessory pathway, thus leading to ventricular fibrillation. So we're taking this patient from a rhythm that is abnormal, but one in which they still have a pulse, until if we give them adenosine, we can make them go into a more lethal arrhythmia requiring CPR. Number 19, what is the effect of administering calcium gluconate in hyperkalemia-induced cardiac arrest? This one is easy. Do not overthink it. Administering calcium gluconate for a reason. Is it A, reduces potassium levels, B, stabilizes the cardiac cell membrane, C, increases sodium level, or D, blocks calcium channels? What is the effect of administering calcium gluconate? Revealing the answer in 3, 2, and if you chose B, yes, it stabilizes the cardiac cell. So hyperkalemia or high potassium is a disorder that can be fatal if left untreated. So treatment should be started with calcium gluconate to stabilize the cardiomyocyte membranes, followed by insulin injection and B, agonist administration. Dialysis may also be warranted. So this is why when we have a patient with renal failure, they're on a low potassium diet or a renal diet because their kidneys cannot excrete the excess potassium. And having too much potassium in your bloodstream can cause your heart to go into an abnormal rhythm. So we could give calcium gluconate, we can give them insulin, but if it's really severe, once the cardiac arrest event is over, they're going to need dialysis. Number 20, which medication is used as an adjunct to epinephrine in cardiac arrest due to opioid overdose? Is it atropine, naloxone, amiodarone, or adenosine? Yes, you are correct. Yes, yes, yes. So proud of you. It is B, naloxone, also referred to as Narcan. So, naloxone is used as an adjunct to epinephrine in cardiac arrest due to opioid overdose to reverse the effects of opioids. So, if you have a person who is suspected of having an opioid overdose and they are in cardiac arrest, you start your CPR. You're not worried about Narcan. When the paramedics get there or whenever your rapid response team gets there and we have an IV started, we can also introduce Narcan intravenously to help reverse the overdose from the opioids. Number 21, for post-cardiac arrest care, which drug is used to prevent shivering in a patient undergoing therapeutic hypothermia? So we will keep the patient cooler than normal for 24 hours. We will have a bear hugger or a cooling blanket to keep their temperatures around 32 to 36 degrees Celsius for 24 hours. But the person may start experiencing discomfort from being cold. So, what drug do we use? Is it midazolam? Is it amiodarone, dopamine, or lidocaine? We're trying to prevent shivering. And yes, you are correct. It is midazolam. So, midazolam or Versed is used to prevent shivering in patients undergoing therapeutic hypothermia during cardiac arrest. And so, in this image, we have a patient here who's probably in the cardiovascular ICU, but they have the Bear Hugger on, and that's Bear BAIR. That's a brand name, but pretty much it is a cooling blanket. It is designed to keep them cool. The cooler we make the person, the less their brain has to work, and it gives their brain a chance to actually function better once we warm them up. So after a cardiac arrest event, if the patient is shivering or if they are responsive, we cannot use this device because it's just going to make their brain activity work harder. They're going to work harder to try to stay warm. So if you do have to use it, you have to give them a sedative if they are responsive. I hope that made sense. Number 22, what is the recommended dose of amiodarone for stable, keyword stable, wide complex tachycardia? So this patient's still alive. Is it 150 milligrams over 10 minutes? Is it 300 milligrams IV push? Is it 1 milligram per minute infusion? Or is it zero point 0.5 milligrams IV push? Yes, you got it correct. Yes, it is A. So this is going to be our maintenance. We're going to do 150 milligrams initially over 10 minutes, and that's the recommended dose of amiodarone for stable wide complex tachycardia. And so then after we do this initial dose, your doctor will also give you another order for the maintenance drip if necessary. 23, which ACLS drug can be used to treat calcium channel blocker overdose? So we took a blood pressure medication that blocks out calcium. So if they overdose, guess what they need? Is it atropine, dopamine, calcium chloride, or epinephrine? And yes, you're correct. It is C. It is calcium chloride. It can be used to treat calcium blocker overdoses by increasing calcium levels, thereby improving cardiac contractility. 24, which drug is preferred for the initial treatment of a hemodynamically unstable patient with bradycardia? In other words, they have symptoms, their blood pressure's low, they're dizzy, maybe their level of consciousness has changed. So which drug do you want to give? Is it epinephrine, atropine, dopamine, or adenosine? And you should get this right because I've given you this answer 3 times. So for unstable bradycardia, yes, it is atropine. So atropine is preferred for the initial treatment in those who are unstable with bradycardia or heart rate less than 50. 25, which drug is administered in ACLS for refractory ventricular fibrillation after defibrillation and epinephrine have been administered? So CPR is ongoing. We deliver a shock. We give the epi. We switch out compressors at the end of 2 minutes. We do another pulse check. The person's still in a shockable cardiac arrest rhythm. We resume CPR. We shock. What is the next drug that we give? Yes, if you said amiodarone, you're absolutely correct. And so amiodarone is administered for refractory ventricular fibrillation after defibrillation and epinephrine have been administered. And so this is the circular algorithm. I absolutely love it. It's simplified CPR and ACLS for me. In the center, first of all, the blue circle represents 2 minutes of continuous CPR. At the end of 2 minutes, you and your partners are to switch. So the compressor has to switch out every 2 minutes. What I want you to focus on is the internal part of the circular algorithm. It starts off with an IV. So your first cycle, if all you can do is chest compressions and shock and get an IV, great. Second cycle is going to be CPR, shock, and epinephrine. Third cycle is going to be CPR, shock, and amiodarone, or if you don't have amiodarone, you can use lidocaine. And then we repeat that process, go back to epi, repeat that process, go back to amiodarone. And if at that point we don't have success, we really need to be considering our H's and our T's, those reversible causes, because that code's been going on for about 8 to 10 minutes. And we want to make sure that this person, we're doing everything we can to help sustain this person's life. And so everybody, that was your ACLS medication review. I know it was a lot of information, so I need for you to go to fltraining.com. It's going to be towards the center of the page. It's going to say free resources. You can download your ACLS study guide. It's going to have algorithms. It's even going to have the slides from this presentation so you can keep studying. And so I wish you all the best. Remember, the more you learn about ACLS, I think is patient safety. So the more you learn, the better prepared you are when there is a cardiovascular emergency. I know you'll be strong enough to run the code or at least assist the person who's running the code. So you all take care. Have a great weekend, and I'll see you in the next video. Bye, Barad. You did great. Bye, everybody.